Welcome. I'm Karen Eggleston. I'm Director of the Asia Health Policy Program here at the Shorenstein Asia Pacific Research Center. And I'm delighted to welcome you to our colloquium series this year. We're going to have events on 3 decades of universal health coverage in Taiwan on the 28th, and we'll have an event on demography and entrepreneurship in China. Come to see how they're linked in November. But first, today, we're going to be launching with this important topic of medication, innovation, accessibility, affordability. And to ground that in some of the challenges in Asia, 2 wonderful students that I work with, I have interviewed some experts in that area. We're going to show videos of that. So thanks, first of all, to Miley Samantha Hu and Adeline Lau for doing the interviews you will be hearing as you finish your lunch. We're going to hear from an expert from Thailand who serves on their medication review committee about that process, as well as from an entrepreneur based in Singapore.
Privilege for us to have universal coverage of health financing. It really solves a lot of problems that we don't need to struggle individually or as individual families to try to get access. And the mechanisms that the system have in place is quite good. It developed over many decades. Initially, just a decision on what should be provided free of charge in essential medicine. So it's more about very simple medicines in primary healthcare. But over time, it expanded to include more and more medicines, and lately, even new treatments, new medications. But the challenge for new medication is usually they're much more expensive and costly to the overall financing scheme. So decision has been very careful. So as mentioned, there are 2 levels or 2 phases of negotiation. The decision to include in essential medicine list is 1 phase. Actually, before that, they have to register with the FDA, the Thai FDA. That one doesn't include any price negotiation or economic consideration. It's usually safety, efficacy, all the routine. But the negotiation on the price and the affordability happen at the Essential Medicine Committee. They actually one subcommittee or working group that deal with negotiation. And this basically group will look into information about the effectiveness, the side effects, the cost per quality and others, and will negotiate with the sellers. And usually they do it not just one companies, but with multiple similar Me Too drugs, those. And that's one price to decide whether which medicine will be included. But once included, then the actual purchase and negotiation will also use this information to negotiate further. And this can be done by Ministry of Public Health, who control all the public hospitals, about 70% of the beds in the country. Or each of the other public hospitals, they can also have their own negotiation. But they know the agreed price based on the essential risk, and some of them could get cheaper, but I don't think anyone go higher, and it also depends on the time. Another thing is once they're in, they have a chance to be reviewed and get out if there's other new medicines coming in or some others decided they want to go cheaper. So this process is not one time. It's a dynamic process. That's why the committee function is continuous.
So I'm Ed, founder and CEO of Reach52, based in Singapore. Reach52, we're an 8-year-old social business. Take our name from the fact that 52% of the world, or over 52% of the world, can't access essential health services. So we're trying to reach the 52%. The mission and the problem statement is in our name. What we do in practice is 3 major things. We collect a lot of data on community health needs, speak with the doctors, communities, health workers, understanding gaps in medicine access, gaps in health services, what products are available, not available, expensive, too expensive, to often out of stock, etc. And then our 2 main services to fill those gaps that we better understand is training doctors, health workers, and doing screening programs. So supporting service delivery through better training and so on. And secondly, we manage sales, marketing, and distribution of products. So we work with big pharma, generic pharma, consumer health product companies, diagnostic companies to manage the sales, marketing, distribution of products. We start off mainly in Philippines and Indonesia. We're pretty scaled up in India now. That's our main market where we've had significant traction. And more recently, we're operating in Africa as well. You do see some companies doing a lot of product donation. They have innovative treatments, they donate it. You have some companies doing more at cost model. Pfizer has the Accord for a Healthier World. They're saying they're going to make available all their innovative medicines to certain low to middle income countries at cost. So you sort of have donations and then you have these kind of at cost business models. You do see Indonesia, Thailand, India reimbursing some innovative products that align to their strategy. So I think some companies' products are relevant to some country strategies. So in certain cases, you have government reimbursement, of course. You're seeing more patient access and affordability programs. So you have various firms that would look at true ability to pay and look at differential pricing. So yeah, I think it's a spectrum, sort of free and donated, at cost, voluntary out licensing, patient affordability schemes with differential pricing based on income and status. So you can have full price through to various discount levels, right through to government reimbursement, where a company's products align to national goals and policy. And we get a lot of innovators coming to us, sort of saying, "Look, help us with getting the government to reimburse this." And I'm just like, almost like it comes across a bit arrogant to me sometimes. Like, who are you to think the government should reimburse your product versus the million other innovations that are out there in the world, when every time you reimburse something gets pushed out the bottom, right? There's limited fiscal space. So you push something in there to take some money, something falls out the bottom and can't be afforded anymore. No one party can do this alone. As I say, if you imagine all medicines are free unless you've got solid distributors, specialty trained doctors, awareness availability, it won't move the needle. Hypothetically, if you have too much demand and no supply, then you also, probably in my view, create an ethical dilemma of lots of aware people that they have cancer and no cancer treatments or whatever it is. So it really has to be a multi-stakeholder solution.
Well, thank you very much. That gives some information, background of the many issues in this space. We're delighted to have with us today evidence from the US about some of the important strategies here. So I'll introduce our keynote speakers. We're going to launch our Asia Health Policy Program events for the whole academic year. We're delighted to have Professor Rena Conti. She's an associate professor of markets, public policy, and law at Questrom's School of Business at Boston University. Professor Conti is the co-director of the Technology Policy and Research Initiative, joint with their law school, and the Life Science Markets co-lead of the Institute for Business, Markets, and Society, also at Questrom. Professor Conti holds a PhD from Harvard University in health policy and economics. She is one of the global experts on biopharmaceutical pricing, competition, and innovation, and has testified on the economics of biopharmaceutical markets in hearings held by the United States Senate, the US House of Representatives, the US Food and Drug Administration, the Federal Trade Commission, and numerous state legislative bodies. Professor Conti also served in 22-23 as special government advisor to the Centers for Medicare and Medicaid Services, and she's held advisory roles at the FDA and served as lead economist on the establishment of the state of Louisiana's landmark subscription model for hepatitis C virus elimination. We're hearing more about today. Professor Conti also serves as an appointed member of the New Jersey Drug Affordability Council and several other important advisory positions. And her research has been featured in virtually all major US news outlets, as well as others globally. And her research has been funded by many prestigious organizations, US agencies, and private foundations. So we're honored to have her here with us today to share about subscription models for high value, high cost medicines. And just a preview, we'll have her speaking, and then we're going to have moderated Q&A by our own clinician and graduate student, Jackie Chun, and then we'll open up for questions. So we look forward to your questions. Please join me in welcoming Professor Conti.
Afternoon. Oh, I have to stay here. I'm going to stay there. Thank you. Yes. Good afternoon, everyone. It is my absolute pleasure to be here. I've had the most wonderful visit here on campus. Thank you, Karen, and thank you so much for the center for hosting me. So today I'm going to talk to you about subscription models and how they've been implemented in the United States, and some lessons about their potential application in other therapeutic areas. So I'm a techno-optimist and an economist. I believe that we are in the middle of the biocentury, and that not only are we beginning to have medicines that are truly transformative for our health, but the hits are going to keep on coming over at least the next 20 years. Subscriptions are alternative payment methods that improve upon the status quo in a couple of ways. Specifically, under the status quo in the United States, and likely other places as well, we pay per vial, per pill, per episode of care. Subscriptions reverse this. Essentially, what they do is you pay an upfront fee in exchange for unlimited access for a population in a defined period of time. There are a number of pilots that are using the subscription model currently, both in the United States and elsewhere. And I'm going to tell you about one of them and my experience working on it, the Louisiana Hep C subscription model. Specifically, I'm going to review for you both the why of why Louisiana decided to embark upon this model, and some limited take-homes from the implementation and my evaluation of this model currently. And then I'm going to switch to thinking more broadly as an economist. How do I think about what is the actual case for subscription models? What can they be used for? And what medicines or conditions might they be particularly amenable to solve? So this is a general audience talk. So for the economists in the room, there are no equations. There's no theory. There is just really, we're going to start like I start with my teaching life science strategy in the biotech industry for my students. We're going to start with a human story about people trying to make a difference in the world. And then from there, we're going to generalize some lessons that we believe we can glean from that experience. So our story starts with a couple of different people. And in particular, there are some policymakers, and you should note that these policymakers are bipartisan. Specifically, we have Governor Bel Edwards from Louisiana. We have Dr. Rebecca Gee, who is the head of public health for the state of Louisiana. We have Senator Bill Cassidy, who is currently chair of Senate Help, and also is a ranking member of Senate Finance Committee. He's an expert on the treatment of hepatitis C. He's a hepatologist actually by training. And Dr. Seema Verma, who was the director of the Centers for Medicare and Medicaid Services under Trump 1, and who helped bring this pilot to market. Essentially, the Hep C free Louisiana model is a subscription model that brings very specific medications, the direct acting antivirals, to a very in need population to eliminate the prevalence and incidence of this disease in this particular state. I'm going to tell you that story. So to back up, hepatitis C is an infectious disease, and it is a public health crisis in the United States, just like it is in many other countries around the world. In the US, it is estimated to affect approximately 2 to 5 million people. And incredibly, 40%-ish don't know they're actually infected with this illness. The other thing that is very notable about this infectious disease is that the age distribution is bimodal. There are many middle-aged people, baby boomers generally, who were infected with this virus and who have been living with this virus for decades. These folks largely contracted this illness through contaminated blood supply. The other group are a bunch of young people. And those young people largely got hepatitis C through sexually transmitted route, through getting contaminated tattoos, or through being exposed to injection drug use. This is a disease that is costly clinically and is also economically costly from a societal perspective. Untreated chronic hepatitis C infection will, over a long period of time, 20 years or so, lead to liver damage. It will lead to liver cancer, and ultimately it will lead to death. It is a truly dread disease. We also have incredible good news. Over the past decade or so, this illness has gone from being able to be managed by an advanced healthcare system to being one that is actually curable. What's made the change? In late 2013, a series of drugs became available in the US market called the direct-acting antivirals that basically changed the game. This disease went from being really, really human, costly, expensive to treat. In other words, the treatments were very onerous for people to undergo, to being an oral pill that people take once per day. The first product was launched by Gilead Science, which is just down the road, a couple of hours from here, with a product called Sovaldi. This product was very famously launched in a brilliant form of marketing for $1,000 a pill, or $84,000 per course of treatment. Gilead then improved on that technology with a new launch of a new product called Harvoni, which was priced even higher at $95,000 per course of treatment. And there have been a series of additional drugs that have been launched by other competitors of Gilead since that time period. This is data on national sales and use of the entire class of these products since launch all the way through 2025. I have the entire universe of drug sales for the United States in this data. And what you can see is that upon launch of this new set of drugs, we see a very rapid increase up, and then what looks like a rapid decrease down, and then a rapid increase up, and then a little trough again, and then some plateauing. So this is a very interesting pattern of drug uptake, and not one that is typical when you bring a product to market that is truly transformative for people's health. Usually you see a rapid expansion up, and then it keeps on going. What's going on here? Well, in advance of this product getting launched into the United States, there's a lot of buzz about this product coming. And because of that, physicians went out and screened and treated their patients and started to warehouse them, waiting for this product to actually come available into the United States. And then once this product became available, those warehoused patients, if insurance was willing to pay, those folks got converted it into treatment. That's what kind of gets us to that first ramp up. Those warehouse patients then fall off in supply, and it becomes onerous on physicians and on patients to go out, get screened and treated. So these are kind of new cases that weren't warehoused, but are new folks that are getting treated. They're severe enough to get treated given the expensive nature of this treatment. Around 2017, 2018, the prices of the brand products start to come down, not because of the usual route, which is generic competition, but instead because brand competition starts to depress the actual prices paid for these products through discounts and rebates. And we see an uptake in the utilization of these products at a cheaper branded price point. Right around 2020, we see a very significant fall off. If you were around then, you know what happened, right? But COVID fundamentally altered the trajectory of people getting screened and treated for this therapy. And then what we've seen is a slow ramp up, certainly not back to pre-COVID levels in the use of this therapy over time. So what is going on? These products, even in the wealthiest country on earth that has the most expansive and generous health insurance and availability of medicines for those that can need them, has a fundamental access problem. Why? First off, 40% lack awareness of infection. That means these folks have to actually get screened in order to be identified as being treated. And up until very recently, there was no point of care test that would convert easily and in an efficient way undiagnosed folks to known cases. Secondly, the population that is the well of the infection, the folks who are most likely to not know that they are infected and or eligible for treatment, are fundamentally underserved and hard to reach, including folks who are incarcerated or who inject drugs. Even with brand competition in this space, prices have come down to approximately $24,000 per treated episode. Costs are still high to treat, and fundamentally the screening costs are also high. You have to work very hard to actually find people to actually treat. And insurance coverage restrictions fundamentally restrict people from gaining access, and this is particularly the case in payors that have very limited budgets, which I'm going to talk about more in just a second. So in 2018, leadership in Louisiana faced very fundamental choices. They could spend their money on screening and treating patients who were infected with this dread disease, or they could spend money on implementing their long-term goals in public health to help kids with asthma and other conditions, and many other public health goals they had, including screening and treating and managing folks with HIV. And Louisiana also happened to be very, very significantly impacted by the opioid crisis. So they had a lot on their plate. Every dollar spent on either Hep C screening and treatment and or meeting one of these other public health goals could also go to other parts of the state budget, which include roads, schools, public transportation, public security, etc. So leadership devised a hepatitis C free vision and plan. They faced particular motivation because in addition to the significant opioid crisis, they also have one of the highest incidence of HIV, and HIV opioid incidents, opioid crisis incidents, and Hep C are co-occurring. In addition, they are among a very handful of southern states that have a very high estimated prevalence of hepatitis C. So approximately 40,000 Louisianans across the board were estimated to have chronic hepatitis C infection. Only in 2018, 1,000 Medicaid beneficiaries were being treated with these new products. Why? Budget constraints, not because there weren't unmet need. And the state had already committed to spending $45 million on these products, or $45,000 per treated person. That's a lot of roads and schools, by the way, and kids who are being untreated or choose not to be treated for asthma. So what did the state do? They essentially, with a lot of work behind the scenes, requested proposals for companies that would be willing to engage with them to be partners in implementing a hepatitis C elimination plan. They ultimately took bids from a number of manufacturers and decided to give the winning bid to a Gilead subsidiary, which is Oswego. They allowed unrestricted access to a generic, an authorized generic of one of Gilead's follow-on products, Epclusa, at a low price. And they also committed to expanding screening and treatment to Medicaid and the incarcerated. The state expected to treat approximately 30,000 residents with DAAs over the time period of the experiment. For those of you who are doing the math, there are 40,000 folks. So it's 30,000 divided by 40,000, so approximately 3/4 of the population were going to be treated. And the payment was capped at no more than the annual cost of treating this condition, but purchasing these specific drugs in 2018. That's how they got to the $225 million amount. It operates, so I'd like to say that it operates as an upfront payment with no actual incremental payment, but that is not actually how it works. Instead, it actually operates as a per unit payment with discounts and rebates that are tranched through, with a cap for meeting the actual number of expected cases. The company provided in-kind support for population and screening. This was incredibly valuable for the state. It's a very poor state that is very budget constrained. It started in July 2019 and ran for 5 years. And the state also expanded substance abuse treatment with some of the expected savings, super important in a population that is going to be, that you're going to screen and you're going to convert, you're going to identify as actually maybe or maybe not being infected, but certainly having other unmet health needs. We're going to come back to that in a second. Here's what happened. So this is official statistics from the state itself. They're publicly available. What you can see is starting in at the beginning of the experiment, that expansion of treatment dramatically increases. Again, the state went out and warehoused folks to figure out, okay, this is coming. And as soon as the pilot started, they rolled out treatment to all of these folks that they knew were infected and were eligible for treatment. They were doing pretty well. Sorry. Treating a little bit more than 1,200 per quarter. That's a lot. And then the pandemic starts. Louisiana gets hit very hard. And then they start to actually ramp up over time and now have fallen off. On average, they're treating somewhere between 500 and 1,100 persons per quarter. In total, the state has treated approximately 19,000 medicated and incarcerated persons through June. To be honest, that looks pretty good, right? So this is approximately 2/3 of the entire expected population that the state thought they were going to reach. Okay. In addition to the primary or direct effect of the subscription model, there might be indirect effects that have been documented. So other potential impacts of rapid adoption of these products into the market may have expanded the number of livers that can be available for transplant. This is super important for public health. Why? Because organs available for transplantation are in shortage in the United States. And so screening and treating folks who might not need a liver transplant after all because they've been cured, and or allowing people who could not be donors because they were infected now become donors because they're not. Huge, huge benefit. And it's one that appears to have shifted out supply of livers across the United States, and also produces external economic benefit to folks. It is possible that the availability of these products, and specifically in the state of Louisiana, might have produced mortality declines. Amazing if it's true. I personally find the data on mortality linked to infectious disease, especially post-COVID, to be a little bit challenging. It's also possible that since we are screening and converting to not infected a lot of young people, the actual effect of mortality in this population has yet to be revealed. So stay tuned on that one. And then finally, there might also be employment expansions. Getting sick with hepatitis C is actually a total drag. And it makes you very tired. It is difficult to have a full-time job. It is difficult to take care of yourself, your family, and other responsibilities when you become quite sick. And so it's entirely possible that labor supply might have also shifted out once we screened and treated folks for this illness, but it's actually quite hard to study because of the labor market disruptions in the COVID, but it would be really interesting to investigate using some other methods. Myself and my colleagues are now working on the economic evaluation of the subscription model. I was hoping to have full results to show you today, but I do not. Stay tuned. But actually, it is uncertain from an economic perspective whether this program pays for itself. And that's because it's entirely possible that when you go out and screen and treat a whole bunch of people, you will run into a whole bunch of stuff that they need. And therefore, spending can actually go up. Moreover, because of insurance churn, particularly in state Medicaid plans, but in other insurers as well, it's not obvious that the state actually appropriates the savings from getting people screened and treated, especially the folks who are pretty well and are not consuming a lot of services in the immediate period pre or post. And then finally, and this is something that has been a revelation for me, but something that if you're interested in demography, you probably know already. Because this is an infectious disease, when you treat prevalent cases of an infectious disease, it is possible that the incident rate of the disease can also be altered. And it is possible that the state savings here is both related to prevalent cases being treated and potential savings related to those folks, but also cases averted. And you really need to kind of untangle to what extent is it the primary effect or these indirect effect through the through this incident case averted that that is really driving savings. I'm so excited to show you the results, but I don't have them yet. Okay. There are other countries and other states that have experimented with hepatitis C subscription models. These include notably Egypt, Australia, and Washington State. I think the Egyptian model is the most exciting positive news. Egypt has one of the highest rates of untreated hepatitis C in the world. It affects approximately 1 in 10 of their population. That's amazing, by the way. There are a number of historical reasons why that is the case. And even before the advent of these new therapies, Egypt had embarked upon an elimination strategy for hepatitis C to screen and treat, even with older modalities, this infectious disease. Egypt was also the primary focus of the clinical trials that actually brought these new innovative therapies to market. And through a series of very astute, sophisticated strategies, the country is actually on track to eliminate hepatitis C by 2030. It's an incredible story. Australia was really the kind of fundamental model that Louisiana was thinking about when they were rolling out their subscription model. Australia also had a elimination plan for the disease. And currently, they have screened and treated approximately 2/3 of the population that they expected to convert over to treatment with their subscription model. Neither of these countries have done the analysis to find out whether it was worth it. I will tell you that Egypt, by the last report, has spent $2.6 billion with a B on their elimination plan. This was not cheap. The other thing I'm going to tell you is that although we believe there is good news, at least for screening and treating people in the state of Louisiana, the state of Washington did not fare as positively. And specifically, the rates of uptake and conversion to use look much, much lower than the numbers that I showed you for Louisiana. I believe that is related to a couple of factors, not because of a lack of effort by the state health programs, but because I believe the cost of going out and identifying identifying cases and getting them converted to treatment had a very different profile than the state of Louisiana. More than happy to talk more about that, but for now, just know not all of the experiments in the United States look as rosy as Louisiana today. The experience of Louisiana, the experience of other states that have implemented this model have induced bipartisan support to pursue a national subscription model to eliminate hepatitis C in the US. There's a very highly detailed proposal that was informed by much of the experience in Louisiana and written or informed by the opinions of those folks that I showed you in that first slide. By the Biden administration in 2023 and 2024. One of the really exciting things that I think is going to really alter the landscape in the US is that point of care tests have now been approved by the Food and Drug Administration in 2024, and that should dramatically bring down the cost of screening and converting over to treatment those cases. The CBO estimates through projections that a national hepatitis C model based on the Louisiana model, where it's the state Medicaid programs and the Bureau of Prisons that will be the direct beneficiaries, will generate savings for society of $6.6 billion over 10 years. It is not chump change. And that is not including all of the labor market and other indirect effects that I mentioned earlier. Right now, the legislation has been introduced into the US Congress floor by Senators Cassidy and Van Hollen. It is a bipartisan bill that is supported actually quite dramatically across the parties. It has been introduced, but it has not been passed into law at this point in time, but we are hopeful it will move at some point. So to sum up, let me tell you a little bit about my lessons learned from being involved in this experiment to date. Subscription models promise to expand access, reduce the burden of disease, and produce savings. They require a lot of effort by policymakers, by providers, by payors, and by diligent companies who want to do the right thing and who might have other motives as well. We'll talk about those motives shortly. The last persons to be treated are likely the most expensive, and have the costs come down with technology? Yes. Might there be other opportunities to deploy other types of technologies to go out and screen and treat likely people that might help? Yes. But the reason that we have not gone all the way down to elimination yet in the US, in my opinion, but in many other places as well, is because these last folks are really costly to identify and screen for eligibility for treatment. And lastly, at this point in time, there are no systematic economic evaluations of whether this effort, which is quite dramatic or quite significant, actually pays for itself, either in direct or indirect costs. Okay, so now I'm going to flip over for the last bit of time and tell you what, in my estimation, are the use cases for new pilots and what is not. To do this, I'm going to put on my economic cap, but I'm not going to show you any equations, I promise. What I'm going to do instead is reason about this through first principles. And I'm going to talk to you about who is actually paying for these things and what are their incentives, who is actually pricing things and what are their incentives, and how might these incentives be misaligned, for which subscription models might solve some problems. Okay. So, you all are experts on this, but just to start, payers face coverage incentives for new medicine that look like the following. They want to provide access to proven high quality, safe, and effective medicines that keep their beneficiaries happy and in good health. But they don't want to waste premiums, because after all, those are foregone wages, or tax payments that have other uses on inputs to health or that patients or they themselves will not reap the benefits of. In addition, they need to be mindful that there is a cost to doing nothing that they will incur or some other potential payer might incur. And we're going to think about that trade-off in just a second, in a little bit more detail. And this is especially important for diseases with spillovers, which can include infectious disease, obviously, but isn't only related to infectious disease. So my great example here is that many diseases that affect children have direct costs on their health but also have indirect costs on families and their ability to work and take care of themselves, and on the educational and labor market outcomes of those kids. So it doesn't have to be health spillovers, it can be economic spillovers as well. And then finally, there's a budget. What that budget is, I don't know. We're going to talk about it in a second. But ultimately, there is a budget, and the price times quantity of all medicines or all healthcare, depending on how you think about it, needs to be satisfied and cannot be exceeded in some meta sense. I believe that payer budget period is actually critical to access policy. Specifically, payers typically set their budgets annually based on expected projections of spending, price times quantity. The budget can have some flexibility if the benefit is realized over 1 to 3 years. I'm going to talk a little bit more about that flexibility in a second. Some special or rare diseases might have special considerations that allow for a little bit more flexibility. But generally, you should think that payers are setting a budget with an annual or a couple of year horizon, not more than that. If a treatment is budget busting due to high expected spending, which can be driven by high prices or high quantity or both, outside the 1 to 3 year window, one should expect coverage challenges. That doesn't mean that restrictions are imminent, but it just means that our systems will introduce fundamental frictions. US payers vary in their budget flexibility actually quite dramatically, and I know this is true for other countries as well. Medicare has an annual budget period, but they have fundamental budget flexibility. Why? Because we don't really deny care to seniors generally. And we provide essentially near universal coverage to those over the age of 65 and the disabled. And with very rare exception, we pretty much cover anything that has FDA approved. And in fact, a lot of my work in this space has been about how documenting that Medicare actually covers stuff that is on label and off label. It covers stuff that has very limited evidence to support its use, and also a lot of things that are very effective and cost effective. Commercial and Medicaid insurance data is very different in the United States. Commercial insurers have an annual budget based on the wages that they collect, the foregone wages that they collect from their insured. They have some budget flexibility, usually 1 to 3 years. They insure largely the employed population under the age of 65. And because they're stewards of persons' wages or foregone tax dollars, they tend to worry about wasteful spending and offering a valuable product. In other words, they want to offer insurance that is good and that people want, but they also have to mind their P's and Q's. And lastly, Medicaid has an annual budget. Every state in the United States has a balanced budget requirement, so their flexibility is very, very limited. They take care of 50% of all kids in the United States, most disabled kids and young adults, and the poor. They must also cover any FDA-approved drug, but have some flexibility in how they can manage their spend, how? Through pre-authorization and other hurdles to gaining access. So you should think to yourself, where Medicare really has a somewhat unlimited budget on stuff that may or may not work using standard methods, or may not be cost effective using standard thresholds, The commercially insured and really the Medicaid are the ones that have the most limited budget and for which the frictions in our system are going to be the most challenging to gaining access. In addition, there's churn. Coverage continuity varies quite dramatically by payer, both in the United States and elsewhere. Typically, people are insured by the same insurer in the commercial plans or in state Medicaid programs by approximately 1 to 3 years, and then they move on. They change states, they change jobs, they change insurance carriers. So the ability to capture the benefit here is fundamentally predicated on how much churn you actually expect and in what period of state. There are many payors that have lower churn. I've listed some of them here. You should note the US Medicaid program has the lowest churn in the US population generally. But coverage churn creates frictions to access. Okay, that's on the payer side. On the supplier side, how do companies price their medicines anyway? Who came up with the idea that this product should be $1,000 per pill? Well, there are actually many possible answers to this question. Generally around the world, the US is the highest paying and largest pharmaceutical market in the world, especially for brand drugs. There are economic and cost effectiveness methods for pricing a product. In the US, for the US market, which really sets the standard for everything else, the US is using an economic method. I'll tell you about that in just a second. But Europe and other countries typically use cost effectiveness, where that's a cost effectiveness method for which they take the US set list price. Why? Because you're launching in the United States first, the highest willingness to pay. And then you're imposing cost effectiveness thresholds country by country or population by country outside the world. In the US, the economic market or method for pricing has two components. The first is related to demand. Products are higher priced if they have demonstrated safety and efficacy relative to the next best alternative. In this setting in particular, the next best alternative sucked. Excuse my French. And also may include other potential clinical or economic spillovers. How can a drug company expropriate that as benefit? If they're exercising monopoly power. If they're not, they can't. Or it's much more difficult. Side effects, convenience, going from infused and injected chronic treatment to an oral pill that's literally one and done in 8 to 12 weeks, which is what these products are. Amazing. People will pay for that, and they pay a premium for that in the States. Hope, also, we have seen being a justification for very high prices. Fundamentally, on the supply side, the ability to charge monopoly prices has to do with regulation. Specifically, we award patents and other market exclusivities that give drug companies the ability to exclude others from competing in their product space. Why do we do that? Because we want to pull innovation. And in fact, the patents and market exclusivities that we have in the US are and the reimbursement that goes along with that are the two single biggest reasons why we have the drugs that we have and why they frankly cost as much as they do. Finally, pharmaceutical companies must cover their cost to make the next available unit. So their cost of goods must be covered. And this is important because products that are more costly to make, literally like every incremental vial or pill, should, from an economic perspective, be more expensive, holding all else equal. And finally, there's a budget. Can't charge many millions of dollars for therapy to consumers if no one is willing to pay. But in the United States, there's plenty of people who are willing to pay very high prices. Okay. Medicine companies profit maximize given these incentives for the US market, and the rest of the world lives the consequences of those. And here's a fun example. Managers at Gilead set the price of $84,000 for Sovaldi in the United States. Anyone know what they charged Egypt? Fun fact. $800. This is the list price. Egypt got them all the way down to actually less than $100 per treated person. But that's a dramatic change. Why? Is there a dramatic change? Price discrimination, they can. Okay. Given this setup, you should think that along the cost and quality axes, that the US system pulls new medicines that have high prices and actually vary in their quality. We have been talking about drugs that we believe have very high quality. They are curative. They appear to be cost effective at traditional levels in the United States. But there's a lot of drugs out there that are not worth it. And actually much of the work that I have done and the work of other economists have shown that we actually live in this kind of schizophrenic world. It's up to payers to actually discriminate. This is actually where I think subscription models have a role to play. Under our status quo, our system allows for maximization of drug company profit and assures innovation incentives continue. But it has fundamental disadvantages. It can lead to overspending on medicines with very uncertain benefit and maybe even actual risks. It can also lead to underuse due to payer constraints, especially if they're budget buster or there's uncertainty over benefit. And there can be misallocation of risks as well. Patients who are the least able to pay, the less able to advocate for themselves, the more disenfranchised from our healthcare system generally, are the ones who are most at risk for access challenges, especially when the payer is deciding on an incremental basis, do I give this to you or not? Alternative payment models solve very specific challenges in this setting, given the status quo. One challenge is addressing the uncertainty in benefit. In the US, we use outcomes-based contracts. Other countries do this as well. Some people might consider this to be managed contracts or money-backed guarantees. We have a variety of those type of contracts out there. That is solving a very specific challenge. But that's not actually the challenge that subscription models are solving. Instead, subscription models are actually solving a different challenge. They're addressing under-provision related to the social benefit of the product, either in direct or indirect benefits relative to their costs, and the misallocation of access due to budgetary constraints that are short-term when the benefits are actually accruing over time. Okay, so what are the advantages of a subscription model? In my estimation, it is resolving budget uncertainty for the payer when the expected demand is significant due to demonstrated safety and efficacy. People want to use these products, doctors want to use these products. Why? Because they're curative. It can incentivize broad treatment access that overcomes our current frictions. And it reduces revenue uncertainty for sellers, which has this knock-on effect of saying, if you bring curative therapies to market that sure, for a lot of reasons might be expensive, we will pay for them. There are fundamental disadvantages. The risk of overpayment is great. If the payer fails to get the patients treated, or if there's imminent competition that reduces products prices below the subscription price. What if a generic became available that fundamentally altered, like 90% off what the brand was willing to pay here, even in a brand competitive market? Well, the state would have overpaid. We can have exactly the same challenge at the national level. And also, if you don't write the contract right, or don't allow for therapeutic evolution, you can actually lock yourself in to a technology that is frankly subpar. Or you might signal, don't innovate in this space because we only have a fixed budget and we've already picked a winner. Thank you very much. So you do have to be careful. I'm happy to talk about this in Q&A, but I do think this is an issue for contracting and one that we should think about a little bit deeper when we're pursuing these in the future. I have 2 more slides and I'm done. Subscription models fundamentally require sellers' cooperation, which means you need to really understand why the companies might be motivated to make the deal. It requires voluntary negotiation, which is going to hinge on their incentives. And I've thought about this a lot, but just I like to think of it as it's either company specific or competitive specific. Either the company is really worried about assurance of revenue in the relatively short term. We actually, Boston Cambridge has a company that was the darling of folks who are really interested in curative therapies, called Bluebird Bio. And they actually just got sold for essentially peanuts because they could not break through getting folks to actually use their drugs because of this budgetary challenge. And I think if you approach them at a reasonable time period, they would have been loved to think about a subscription model, or they actually signed outcomes-based contracts as well. They just couldn't get there. But small biotech may be willing to make a deal, else face reduced revenue that could actually be existential for the company. In addition, companies facing brand competition may be more willing to make a deal to assure their revenue. Why? Because a product a unit that they're selling is a unit that they're actually taking from their competitor. And again, this has some implications for writing a contract that actually might allow for multiple sellers to assure supply, and might have other consequences on what you actually get to in terms of price. This leads me to think that there are some reasonable subscription model targets for the future that meet certain criteria. The first is there's certainty regarding patient benefit. That could be possible cures, but they don't have to be. But they have to have significant demonstrated clinical value and maybe some spillovers as well. They're cost-effective outside the typical payer budget window of 1 to 3 years. Why? Because it's exactly the friction of the flexibility that you're trying to solve for. There's a high probability of undertreatment due to the other systematic frictions, which might include churn and other things. It's worth it because the cost of implementation, the cost of negotiation, the cost of actually getting the system to align is worth it due to the actual fundamental costs of inaction, which might be in human life, it might be in economic productivity, it might be for other reasons. And finally, this is a voluntary model, so you have to have sellers who are actually willing to engage for their own economic incentives. I'm going to end on this last thought, which is a lot of people ask me this question. I do not believe that the right price for a subscription model is all the way down to the marginal cost of production. Why? Because we're not trying to bankrupt these companies. In fact, we are trying to balance access with incentives for future innovation. That produces a lower bound. An upper bound is the best price that it's offered by the seller outside the pilot. That gives you a range. There are other things that the companies can provide that might be worth it and that you should think about how to pay for or reward. That might come through a price, that might come through other things, depending on your system. But payers must commit the resources to treat the minimum number of patients to break even, or else their money is not spent, the effort is not spent. But companies can help in providing in-kind support for your subscription model to identify patients, get them treated, help defray other costs of implementation, which are not peanuts here. And with that, I will say I very much look forward to your comments and your questions and debating this more generally. You can reach me here. Thank you.
On behalf of all the audiences here, I would have to thank Professor Conti for this very inspiring talk that we all wish that we would see the application of subscription model more on this world, perhaps not only outside, not only in the United States. And hello, everyone. My name is Jackie. I am, let me give you a very small detail about myself, that I am a OBGYN doctor by training and specialized in gynecologic oncology. I have seen my patients suffering, anxious, awaiting for the new technology to gain through approval or reimbursement approval. And also, they suffered from financial toxicity from the financial burdens of those new technologies. So my first question for Professor Conti would be rather straightforward. Since we talk about the pros and cons, well, I guess the advantages and challenges of prescription model, would signing of the advanced purchase commitments, which subscription model is under this umbrella term, risk locking in one supplier?
Yeah, I mean, the whole point of these type of models is that you're trying to negotiate with a seller for voluntary access to their product at a lower price than you otherwise would pay. And so the tendency is to think, oh, I'm going to pit competitors against each other and take advantage of their own incentives to get to a deal. But that risks, number one, not being able to supply all those products to the people that you intend to treat. If there is just one supplier or just two suppliers and everybody is rushing to do a subscription model, well, you have a shortage potential problem, and then you have allocation concerns. I like the idea. So in Louisiana, we didn't have to deal with this because it was a very small patient population that we were ultimately addressing, and the suppliers could meet that demand. But in COVID, we certainly had that challenge, right? That demand far outstripped supply. And so, and there are many circumstances for which you'd think actually having more than one supplier entering into this deal might be great for the population and might also be great for themselves. So I don't think that you have to lock in to one supplier in order to get a good, in order to get a population health positive outcome here. But the circumstances really matter. The other thing that you mentioned that I think is really astute is that there is therapeutic obsolescence. So you don't want to lock in for a really long time period, or not have the option to rethink what are the clinical characteristics of a product that you want to do some sort of subscription model in, to allow for therapeutic innovation. And here's where advanced purchase commitments, which are different than subscription models, I think have a really great idea. Advanced purchase commitments are agreements in which before the product is launched into the market, the payer says, hey, we would like this innovation, and at a level of quality and cost that pulls bids in to actually companies saying, yeah, I want to make that product. And then in exchange for meeting or exceeding that bar in quality, there is a reward to the companies that bring those actual products to market. That might sound familiar. We did this for COVID therapeutics and vaccines, but actually we've done this for other things too. And my colleague at the University of Chicago, Michael Kremer, and Chris Schneider at Dartmouth are really the experts in thinking about these advanced market commitments more generally. Those agreements tend to have kicker clauses where they will allow for innovation. And they'll say, here are the elements of innovation that we find particularly valuable for this set of products and these sets of populations. So if you bring a next generation product to market, we're interested. And we'll actually expand the subscription model to allow for that type of therapeutic innovation. In my estimation, I would love for subscription models ultimately to become actually a version or the next version of advanced market commitment, where the US and other countries say, hey, there's a whole bunch of stuff that we really, really find valuable and we want companies to innovate in. We will set the incentives for that innovation. And once you bring these products to market, we will guarantee that people actually get access to them.
Thank you, Professor Conti. As someone coming from a different healthcare system, compared to the United States, which is a multi-payer system, Taiwan is a single-payer system with universal coverage, and we're actually celebrating our 30th year of national health insurance reform this year. Many of not only Asian countries, but also many emerging market countries, they are trying to establish their setting up their own health technology assessment and reassessment agencies. So my question to Professor Conti would be, what are some of the minimum requirements or minimum infrastructure build for another system to take over and run this advanced payment model responsibly and taken health equity in mind?
Yeah, great question. You need health economists. Yay!
I do have to say, we appreciate that. Well, just me, I appreciate that you decide not to put some equations in the slides.
No, I think this is a very important question, and all kidding aside, you need health economists and you need clinicians and you need folks who are experts in serving underserved communities to all be in the room thinking through what is actually the threshold that we want to set for both access and equity. And you need measures that hold companies and the payors accountable for delivering on that promise. One of the things that I think is really fascinating about working on this topic has been that in all the models I have seen where access is actually being guaranteed, it is a partnership between the payer, the health agency, and the companies. It is not an adversarial relationship. You need each other. And there are rights and responsibilities on all sides.
Speaking of timely access, Professor Conti, are there any good examples around the world or among the United States that signing this contract of subscription model would accelerate the payer's reimbursement decision, since we're talking about the anxious of patients awaiting this approval? Has there been any evidence or examples of such good experience?
So subscription models are really distinguished from advanced purchasing models in that they tend to be applied in areas where the product is already launched and available in the market. It's become obvious to everyone that because of payer frictions, people aren't going to get access who really could benefit from the treatment. But you can imagine that if we had criteria and a smooth pathway for screening and screening and identifying therapies and populations that might come to market and might have these frictions in advance, you could kind of see how you could get to some sort of advanced purchasing commitment that also is kind of that ends into a subscription model. I would say in Louisiana, the time between approval and the launch of the model was 5 years. That is a lot of suffering, and the cost of inaction is high in that population. And I'm sure that is the case for other subscription models that I see. Why? Because there's just frictions in getting this together. If we had a pathway that allowed this to be much more easy to do, and it wasn't so one-off, that we could actually identify and screen and scale, that would be amazing. We're not there yet.
My last question for Professor Conti would be, since subscription model seems to be setting in a defined population, defined time with defined budget, how, like when a payer is designing this payment models, how could they build future possibly entry of generics, entry of biosimilars into their whole like multi-year agreements contract?
Yeah, I mean, the price might have to come down. Price might have to float on generic or biosimilar competition, or could be renegotiated once that triggering event occurs. You could also have a triggering event that was about therapeutic innovation. There's no reason that contracts couldn't handle that. And actually, I can think of some specific medication classes for which one might want to actually think about doing that. But again, it's not obvious to me that you want to bargain down these prices in advance or in expectation of generic or biosimilar competition to get to 80% off, 95% off, because again, that's going to tamper or damper any willingness by the companies to actually want to make a deal in expectation if they think that, oh, this is just really a pricing game where you're going to embarrass us on our price, and what you really want is a headline that says we're going to get you all the way down. So I think you need to think about the incentives on all sides before you pursue such a draconian policy that would get to prices that are that low.
Thank you, Professor Conti. I think I'll open the mic to the floor for people who have questions. Please use the microphone and perhaps give us your name first.
Thank you, Professor Conti, for the talk. I'm Adeline, but yeah, one thing I wanted to ask about was that, so in the beginning of the talk, we had the clips, and in one of the interviews, Ed mentioned the importance of demand. And as you mentioned in your talk, the demand, which means like screening and making sure that we actually know who has a condition, who needs to be treated, is incredibly important. But when you actually go into policy of trying to pass such a multifactorial policy of both the subscription-based model and also educational initiatives and treatment and identifying patients, these types of initiatives are very hard to pass all at once within like legislatures, because I actually read one of the reviews about this was that they tried to pass many different things, but only in the end, only the subscription model got passed. So my question is regarding actually private sector companies that are taking this up. So I know that Andrew Lowe has a company, Conti Health, that is doing subscription subscription-based payments now, and some companies are considering, like insurance companies, with the like big pharma companies making these deals directly without the involvement of policy. So I wanted to hear your perspective about private sector companies taking up the subscription-based model directly.
Yeah, so there are a number of different companies that have been formed to try to solve these challenges outside of government. I think this is a fantastic innovation in the private sector. And it is entirely possible that the private sector can resolve some of these frictions and scale up across therapies or across populations that might be in need in a way that the government or state legislatures might have a much more difficult time doing. So I'm hopeful that either this is going to be a technology solution, that this is going to be a government solution, or that private companies will step into the breach.
Thank you.
Hi, Dr. Conti. Thank you for the talk. I'm Harry. I'm a PhD student in health economics here at Stanford. I've been thinking a lot about patent buyouts lately, and I'm wondering if you've thought about that as well, and how that would be different from this sort of subscription model, basically having the government or a set of payors purchase the patents and the market exclusivities from the original brand company, and then licensing that out to generic manufacturers. So then, yeah, just bringing it straight to generic competition, but yeah, trying to commit substantial payment up front to allow the branded drug to give up that exclusivity.
Yeah, so great question. And I resisted the slide on patent buyouts, so perfect. Patent buyouts, I think, are an interesting solution. The challenge is that patent buyouts don't have the guarantee that you're going to go out and actually get people treated. Right? So they require additional steps to commit to a democratic process, to pay this money up front, and to actually go out and get people treated. You also have to rely on the private sector to actually go out and make these things. Not obvious if they want to make your product relative to other things that they could likely make more money on. So there are some very significant frictions attached to the patent buyout idea. I don't think it's dead in the water. In fact, there are some medicines and some other essential products as well, or critical products as well, that have that type of, that have been the subject to patent buyouts. Usually they're kind of not very well reported, in part because companies don't like, well, maybe I'll say it this way. Patent buyouts can retard innovation in specific areas, especially if there is a perception that the patent holder doesn't get a good deal on the agreement. I am very intrigued, particularly in the developing world context, about local production or other types of agreements where you're managing the license to allow for production for a particular population. The Egyptian example, one of the things they did that I think is so fascinating is that they actually entered into an agreement with the brand manufacturers, but ultimately converted that agreement into a local manufacturing agreement for the Egyptian market, which then creates all sorts of really interesting economic spillovers.
I want to make sure I understand sort of the model. So the way they set the initial budget of 225 million was based on the spending on hepatitis C treatment for those for a year period, or?
Correct. It was the annualized budget of the state in 2018, before the subscription model started, across the entire state Medicaid insured population. And they took that budget and said, we'll give you this amount of money for 5 years in expectation that we will get an unlimited amount.
Right. So it allows them to manage their budget and not exceeding the existing annualized budget.
Exactly.
Where does the commercial players come in? So this is the Medicaid budget. So do they get the same pricing? Do they not have to pay for anymore? How does that work for people with commercial?
Great question. So state Medicaid plans, which are fee for service, and the managed care plans that are actually quite common in the state, both of them got access to the deeply discounted product for their population through an ungated formulary that the state put in place. The commercially insured patient population was not a part of the deal.
Okay. So
that is not what happened in Washington State. In Washington State, state Medicaid programs plus state employees programs got access to the state negotiated deal. So you can imagine it. You can imagine payor type and inclusivity varying by the deal.
I see. And do they have any sense of what percent was under commercial insurance versus, state Medicaid or insurance?
So I have a slide on that, which I don't have with.
But that's okay. No, I'm just curious. So
my impression is that in a lot of the U.S., the well of the infection that hasn't been treated so far is in the state Medicaid populations.
Okay. Yeah, because you mentioned that most people don't know that they have hepatitis C. And so even to make that estimate of how many people have hepatitis C, how many you should be getting, because you're going to identify more people, which will cost more. Yeah. That's interesting. Thank you.
Yeah, thank you.
Well, please join me in thanking Professor Conti.